Hello, I am Dr. Kelvin Moses, Associate Professor of Urology at Vanderbilt University Medical Center. I want to welcome you to the ZERO Health Equity Symposium. I'll be speaking today about cancer disparities with an emphasis on prostate cancer and talk about some of the historical context, some of the current challenges and myths that we deal with in the medical system. I have no disclosures to report. So let's start with the basics. What is a disparity? And the Cambridge Dictionary defines that as a lack of equality or similarity, especially in a way that is not fair. And while we know that life is not fair, we would like to have our healthcare as fair as possible for all populations. And when it comes to health disparities, that is actually very specifically defined as population-specific differences in the presence of disease, health outcomes, or access to health. And a lot of our talk will go over some of the issues that each one of these describes: disease, outcomes, and access. So if you take away anything from this talk, some of the themes that we'll discuss: number one, racial disparities in cancer and in health overall don't occur in a vacuum. And that means that it just does not just occur in the clinic or in the hospital. Racial disparities will not go away if we ignore them. So I know there's a lot of people who wonder why we're still talking about this, or if we keep talking about it, then that just increases racism. And it's really the opposite. If we don't discuss these things, if we don't come up with strategies to fix these challenges, then it will never get better. And lastly, race in itself is not a risk factor, nor is it really a biological entity. Race is a risk in terms of how the health system interacts with patients. However, it is not an inherent defect that causes disparities that we see in health. So just briefly, I want to look at cancer incidence in men. You can see the top two lines. Black men have always had higher incidence compared to white men and have always had worse survival. So these are death rates. And you can see a decline over time, and a lot of that is due to decline in prostate cancer deaths. However, there is a significant gap between Black men and white men. And if you look at all cancers and 5-year survival, Black or African American have a 7% increased risk of death compared to whites in this country, which translates to hundreds of thousands of lives over many years. And so why do health disparities exist? And it's because they're supposed to. It's the way that our American system has been created and perpetuated over time. And so this is the part where I'll talk a little bit about the history, particularly how it has to do with our medical system. So in the pre-Civil War era, the majority of Blacks were enslaved and were really given just the minimum amount of care to maintain productivity, but it was always less than the care given to whites. And commonly, once healthcare outstripped the usefulness of an enslaved person, it was actually withdrawn. And many people were sold off as test subjects for medical experimentation, or their bodies were sold to medical facilities for experimentation or cadaver studies. And the medical profession played right along with the prevailing attitudes of that time. Just one example shown here is Dr. Samuel Cartwright, who was a professor at the University of Louisiana. And in his medical textbook, he theorized that Blacks should be medically treated differently because they are non-human. And he prescribed beatings and all kinds of torture, essentially, to rid African Americans of their drapetomania, which was runaway madness, or dysesthesia ethiopica, which is basically disobedience. And he would actually prescribe that other slaves should beat the slave so that it gives an example to the others to not perform or not display such attitudes. Another example, a very famous J. Marion Sims, who's known as the father of modern gynecology. He purchased several women and performed multiple surgeries without anesthesia in his experiments on vesicovaginal fistula repair. And this is a very famous painting that formerly hung in one of our medical museums here in the United States. Some of these women were operated on 20, 30 times to the point of extreme pain, infection, and eventually death. As we saw over the last couple of years, there's been an effort to get rid of statues and honorariums to people who performed heinous acts. And this statue of Dr. Sims was removed from Central Park just last year. So some of the mythology that is perpetuated by this era in our history is the persistent Black pain mythology. And it continues to this day. In a study that was done at one of the hospitals I did my residency in 2000 showed that Black patients with broken extremities were less likely to receive painkillers when they went to the emergency room. In a survey of medical students and lay people in Charlottesville, Virginia, people concluded that Black people had less sensitive nerve endings and thicker skin. And that plays into some of the thoughts of how Blacks are treated when they enter the medical system. It also creates a cultural memory among the African American population. There's a very strong sentiment that going to the doctor will expose you to non-consensual experimentation. Your pain will not be addressed. Or even admitting or discussing your illness may cause you to lose your job or lose your worthiness to society. And many men and women will feel that they are no longer virile or fertile, do not deserve care, and some may feel like they are not worthy of care. So if we go to the next era in American history, which is after the Civil War, Emancipation and Reconstruction, it's still a segregated society. And even in hospitals, Blacks were not allowed to use those facilities in the North or the South. And I bring up that point because everybody wants to point to the South and how backwards it can be, but the North participated just as thoroughly as the South did. And also Blacks were excluded from medical and nursing schools. And so many of them created their own schools established by the Freedmen's Bureau. Most of those hospitals went away over time, but there are examples of those hospitals all over the country. They did have unequal and separate facilities, and they were created for the sort of undesirable populations. But because there was some increased access to healthcare, even if it was less than standard, there was improvement in health status among Blacks in this country. This period ended with the institution of Jim Crow laws. And at that point, there was severe restriction to access to healthcare and in general, severe restriction in general society to the movement and freedom of Blacks in this country. Because of this exclusion and segregation, Black physicians and nurses actually created the National Medical Association, which exists to this day, and of which I am a member. And their goal was to improve health outcomes for African Americans in this country and increase access to healthcare for vulnerable populations. So after Reconstruction, you had the Supreme Court decision, Plessy versus Ferguson, which in writing said separate but equal, but in fact established separate and unequal institutions in all aspects of life. And the medical establishment fully embraced this. And so facilities that served patients, if they existed at all, were clearly substandard. You continue to have medical experimentation, the famous of which, of course, is the Tuskegee syphilis study. But there are several others, and I'll mention some of them a little bit down the road. Blacks continue to establish their own medical schools and hospitals, and again, some of which still exist in some form or another, again, to combat the exclusion in facilities for medical care. But this time was also rife with violence in the post-Reconstruction era. And there are several examples of this, but the most famous would be the Tulsa Massacre or Black Wall Street. A prosperous African-American district was burned, many were killed, and there were even private aircraft that were mobilized to drop firebombs over this area. And I bring that up because I remember in the news at 9/11, they said it was the first time that an aerial terrorist attack had occurred on American soil. And I would counter that it had happened, 90 years before. $32 million in damage was caused by this. The Rosewood Massacre in Florida, similarly, several Blacks were killed, Black-owned businesses were destroyed, and many were displaced. And again, I hear the several $1 million of damage. There was a settlement paid by the state of Florida to some of the survivors in 1994. So again, in this era, you had the Supreme Court decision Brown versus Board of Education, which ostensibly led to desegregation, but really in this time you had heightened segregation of spheres of society. You had resurgence of violence and Confederate imagery, and any efforts that were created to remediate the exclusion of African Americans have been systematically dismantled. In 1968, you had the signing of the Civil Rights Act. And this allowed, you had the Civil Rights Act in 68 and the Voting Rights Act in 1965. Ostensibly, this was created to eliminate discrimination in housing, education. But really, since that time, you've seen an persistence or even increase in disparities in cancer, diabetes, hypertension, many other medical conditions. A lot of that is because we have underrepresentation of African Americans among physicians, nurses, mid-level providers. And then there's also disparities in access to care, insurance coverage, and then even just in receipt of appropriate treatment for particular diseases. I mentioned before the Tuskegee experiment, but there are so many others, and maybe not everybody knows exactly what they are, but again, there's this cultural memory and this cultural mythology that derives from this. Dow Chemical injected prisoners at the Holmesburg prison in Philadelphia with various pathogens just to see what they would do. And just recently, Philadelphia paid a substantial, they admitted to this and paid a substantial amount to survivors or families of these prisoners. Margaret Sanger, who is famous or infamous, however you fall along the lines of the creation of Planned Parenthood, but she really was a eugenicist, meaning that she felt that the mentally challenged, the psychiatrically challenged, undesirable populations should be either euthanized or at least sterilized so that they could not procreate. And even more recently, one of the early chairs of neurosurgery at the University of Mississippi would remove portion of Black boys' brains who had been placed in institutions because of quote unquote behavior problems. They had just been kicked out of school for minor transgressions. And there's a building named after him on their campus. One of the more famous programs, it was a North Carolina eugenics program. And I bring up North Carolina because there's a lot of data, but there are actually several states who over several decades sterilized thousands of men and women. You would even have social workers who would go out and find find people who were identified as unsavory. And this program was designed to breed them out. In 2014, state legislatures paid out $10 million in compensation to survivors. And while, again, this may seem like a long time ago, number one, I was born during this time, but two, the past is present. Here you can see over the last, or during the prior administration, immigrants who were detained at ICE centers were receiving hysterectomies, again, probably non-consensual without any medical documentation as to the need for this. And so these things are still happening, and we must remain vigilant and knowledgeable about it. So again, going back to cultural memory, we now have centuries of medical so-called experts who are publishing and discussing the idea that Black persons are somehow not human enough to receive consensual and proper care. Because of segregation and its ripple effect over time, you have the exclusion of people of color and women from the medical field, particularly in area or levels of leadership, which then devalues input from those particular groups. And really, we have a propagation of the stereotypes of certain groups over time. And what we've done then is attribute the outcomes and disparities to personal failings rather than systemic inequities that are built into the system. And lastly, what we've seen over and over again is that speaking out against the norm can be met with verbal, psychological, or even physical threats to your health, to your career, or even to your life. So I want to pivot a little bit to cancer disparities, and I will focus on prostate here in a second. But really the beginning of cancer disparities goes back to the early 20th century when cancer was almost uniformly fatal no matter who you were. But it was perceived as a disease of civilization and culture, mostly because cancer is a disease of older populations. And medical societies did encourage discussion about it, but it wasn't viewed, cancer was not viewed as an important topic among Blacks because they're perceived to be victims of or vectors of infectious disease or violence far more than cancer. And so this is really the beginning of the screening disparity. And it took a surgeon named Dr. LaSalle Lafall, who was the former chair of surgery at Howard University. He was also the first Black president of both the American Cancer Society and the American College of Surgeons. And he published a very important paper in the journal Cancer in 1973, looking at the increase of cancer mortality among Blacks in the mid-century. And among his conclusions, he showed that genetic factors alone cannot explain the rapidly diverging trend over this time period. And remember that I told you the Cancer Society started talking about screening and discussion of cancer in the 30s and 40s. So you're already seeing a divergent pattern. Now he hypothesized that it was an environmental effect, which is not a bad idea because Blacks typically lived in segregated neighborhoods, typically had poor sanitation, typically were located closer to, say, water supplies or power plants or things of that nature. So not a bad idea as far as his conclusion. As we have seen in history, though, whenever a prominent African-American publishes something that criticizes the outcome or the consequences of racism and segregation, there's always a response. And so the American Cancer Society under the direction of Dr. Herbert Seidman, published a paper just 3 years later looking at cancer among Black and whites. They did see that cancer was diagnosed at a more favorable stage in whites, and white survival tended to be better even within stages. So people with stage 2 cancer, if you're white, you live longer than a Black person. And so they also showed that equivalent results could be achieved, particularly in cervical cancer, if it was diagnosed at a localized stage. However, their conclusion, which should have been that we should improve screening for cancer and improve treatment or focus on better treatment among African Americans, their conclusion was clearly controlling cancer is more difficult in Blacks than in whites. And again, this is now the definitive statement from the American Cancer Society. And so physicians will now believe this, right? They'll say, oh, it's more difficult. And so that will excuse the poor outcomes rather than focusing on improving treatments. The American Cancer Society did come back with a similar study in a larger group of patients in 2004. And again, this is where that 7% increase in risk of death, but again, and this time, they said the differences in cancer between groups are unlikely to be based on cancer biology, but rather differences in treatment, stage and presentation, and mortality from other diseases. And the last statement here is really important. These differences should be the primary targets of research and interventions designed to reduce disparities. And so, as I'll talk about at the end of the talk, we really should go beyond the research and really start looking at interventions. So screening makes a difference. Again, before screening tests were commonly available, cancer was almost uniformly fatal. However, but since screening tests have been established in our society, you've actually seen widening differences in death. That includes breast, prostate, cervix, and colorectal cancers. Treatment also makes a difference. In several different cancer types, it's been shown that African Americans are less likely to receive appropriate treatment. We can see here in colorectal cancer. We see in breast cancer, Black women are actually less likely to be diagnosed with breast cancer, but actually more likely to die from breast cancer. They're significantly less likely to receive treatment, even when matched for stage, have a longer time from diagnosis to treatment, and lower receipt of chemotherapy after surgery. And this is seen in lung cancer, it's seen in thyroid cancer, it's even seen in blood cancers. And so it's not just that there's differences in stage or presentation, but truly a difference in treatment. So pivoting to prostate cancer, I think this group knows pretty well the statistics, but Black men have more than twice the risk of death from prostate cancer and are typically diagnosed with more aggressive disease, but are less likely to receive definitive therapy, including surgery versus radiation. And I'll go over some studies that show this. Black men are also less likely to receive screening for prostate cancer, and as I mentioned before, receive radiation or no treatment at all. In a study that I did several years ago with a group, including Dr. Willie Underwood, we looked at a large group of men and just looked at the likelihood of receiving any type of therapy for prostate cancer, and we looked at it by their risk level. And you can see outlined in blue there, African American. So this is in comparison to white population, and a number closer to 1 means that the treatment is similar to what white patients receive. And as you can see, for a low risk is 0.81. So that means 19% less likely to receive treatment with low risk disease. That number, next number, 0.74, that means that Black men with intermediate risk disease are 26% less likely to receive treatment. And then at high risk, you see that number 0.62. So that means that Black men with high risk disease are 38%, almost 40% less likely to receive treatment. So really, with escalating risk of disease, you're even less likely or declining odds of receiving treatment. And it really should be the other way around. And we see a little bit of that in Hispanic men, not necessarily for low risk, but for intermediate and high risk disease, still less likely to receive care. And when we looked at it in specific treatments, again, you can see a lot of these numbers are less than 1, except for radiation, which is where it says RT. And then the same for Hispanic men, less likely to receive surgery or brachytherapy. Same thing is seen in breast cancer. And sometimes people ask, well, if it's access to care and maybe if patients are insured or highly educated, they'll have equal outcome. But here you can see in women with lung cancer with more than 12 years of education, so high school graduates, Black women are 26% more likely to die from lung cancer compared to non-Hispanic women. Same thing is seen in Black men with prostate cancer. Black men who have 17 plus years of education, so that means they have a college degree and some professional degree, have higher prostate cancer death risk than a white man with less than a high school education. So it's not just about education, it's not just about insurance. There is something in the system that is leading to poorer outcomes in African American men and women. And really, if we take a broader view, we're seeing this in other populations. So as I mentioned, Hispanic men are having worse outcomes, and this will be exacerbated as that population increases. Native American and Alaska Natives have greater mortality to incidence ratio for almost every cancer. And again, it's most pronounced in the screen-detected cancers. And among LGBT populations, there's disparate rates of breast cancer, HPV, which can lead to penile and cervical cancer. And a lot of that has to do with, number one, there are laws that specifically exclude or discriminate against LGBT. There's fear of coming out to a physician or going to a religiously affiliated hospital. And there's pressure to conform to gender expectations, even if you do not fall within neat categories. And so I want to emphasize again, though, race is not a medical entity. It is a social construct. And we use it as a surrogate for status in our society, geographic origin, culture, based on our norms that we set in society. However, there's a lot of people who want to focus on the genetic basis of prostate cancer disparity, and it's perfectly reasonable to discuss that. But it makes sense if you focus on genetic aspect of monogenetic diseases. So sickle cell or cystic fibrosis are a clear association with a single gene. However, we're seeing disparities in almost every cancer. And so you either have to conclude that underrepresented populations are genetically inferior, or there are systematic issues that are negatively impacting patients who are not represented in medicine. So why are we talking about this? Why is it taking so long? Why haven't we gotten to equality or equity? And again, if you look at a timeline of our history, that green line is really when we've been quote unquote free, right? Where everybody who is an American citizen can vote, can participate in society. And another way of looking at it, at least in my family, my generation is the first ones who have been fully American citizens since birth, right? So, because my parents were born before the Civil Rights Act, before the Voting Rights Act. And so we're really a young country when it comes down to truly being a democracy. And again, wherever you fall along the spectrum, democracy is under question or under attack in certain corners of our society. There's structural inequity in every sphere. So again, what we're seeing in medicine is the same thing we see in residential redlining, where neighborhoods are undervalued, which decreases wealth among African American and other communities, which decreases their access to good schools, to good hospitals. There are significant actions, namely among the Supreme Court, but in every state where there's restriction of voting rights, where again, You're not able to vote for the representative who could advocate for your needs. There's inequities in police violence and judicial sentencing. And all of this ends up as a greater risk of bankruptcy among the poor and communities of color. So the elimination of disparities is extremely important. Number one, healthcare is a right for all citizens, and especially in a society that is as wealthy as America is overall. It's a hallmark of a just and humane society, and actually makes sense economically. Dr. Paul Farmer, who was at Harvard University, a health economist, stated that it's actually very expensive to give bad medical care to poor people in a rich country. And what that means is that we spend so much on the back end of taking care of people with either severe disease or emergencies, when if we gave preventive care up front, if we had medical coverage on the front end, we could actually reduce our expenditures on healthcare and actually provide better care overall. So what are some things that are being done? Dr. The chair of urology at UCLA, Dr. Mark Litwin, went to the California legislature to get funding for free prostate cancer treatment in men who had little or no health insurance. And it actually was found to be more cost effective than relying on safety net facilities. We do have the Affordable Care Act, and despite efforts to get rid of it or lessen its impact, it has insured nearly 30 million Americans to date. And in states that have participated in Medicare exchanges, along with the ACA, you're actually seeing improved screening, increased survival. Medicine is moving from fee for service, or basically paying your money and getting a service, to quality metrics. And so that means that physicians who provide low quality care will either have to answer for their actions or see a reduction in their reimbursements. And lastly, advocacy groups are fighting to increase knowledge about health disparities and action. And this is where I'll shout out Dr. Reggie Tucker-Seeley and the entire ZERO group for creating the Health Disparities Task Force and having this particular symposium. That task force is working on advocacy with the legislature, with funding for research, for patient education, and also providing resources for patients who are lower income. So I think a lot of people have seen this picture, but we're trying to move beyond equality and really into equity or justice. So we need to provide the tools to provide care for our patients in the highest quality and in the appropriate way. And this is important because, as Dr. Martin Luther King said, of all forms of inequity, injustice is healthcare is the most shocking and inhumane. And we should be moving forward as a society to provide good health care, not just in prostate cancer, but overall, because we want to be a just society. For those who want to read more in depth about some of the issues that are brought up in this talk, here are some books that have come out recently that describe in detail some of the things that impact our medical system. Thank you for your attention and enjoy the rest of the symposium. Thank you very much.